So our objectives will include to become familiar with the prevalence of mental illness among the HIV-infected adult population, to learn about common mental health issues among these patients, and understand the impact of mental illness on HIV care. So I'm going to spend some time talking about the HIV of today and what basically the face of HIV looks like. With improved treatments and longer survival times, we know that the maintenance and improvement of HIV-infected individuals' functioning and well-being have become major goals of treatment. So we no longer have to focus primarily on their physical care, because luckily HAART has been able to prolong lives and make lives very healthy and with effective treatment. However, if this treatment is so effective, why are our patients not reaching optimal health? And I think this is now kind of the question that research is now looking at, and where clinicians are kind of asking themselves, you know, we have excellent treatment, yet our patients are not necessarily reaching the health that we would expect, and that's, you know, pretty much primarily the concern nowadays. So obviously this question can have many answers, and many factors can impact the reasons why our patients are not reaching optimal health. But for the purpose of today's presentation, we're going to focus on psychological factors. And most recent research is also focusing on how these psychosocial factors are impacting our patients' overall well-being and thus their response to HAART. So individuals infected with HIV, as many of you may know, have many challenges, including maintaining adherence to HAART, disclosure of HIV status, and coping with potential or perceived stigma. So these are issues that all patients or any patients living with HIV can be confronted with. However, for those HIV-infected individuals who also have mental health difficulties, these and any other factors that can exist with individuals living with HIV can be significantly intensified. So they perceive and they experience these factors to a very, very unhealthy and perhaps unmanageable level. So coexisting of HIV and mental illness poses a significant public health problem, and it can represent a difficult challenge for treatment, as many of you healthcare providers in the webinar could have experienced already. So there are many psychiatric disorders, but for the focus of HIV care, I want to narrow it down to the most common psychiatric disorders present among our HIV-infected patient population. And even more so, I want to today focus on depression. So the prevalence of depression increases with the severity of symptoms amongst our patients. So what's important to recognize, though, is that with patients that have these psychiatric illnesses, they're going to also display many other symptoms or behavioral factors that we'll discuss in a little bit that may impact their care. So as you see, there we go. The mood disorders have a substantial negative impact on a patient's health-related quality of life. And for most domains of functioning and well-being, depression is more debilitating than most medical conditions. So given the reason that the prevalence of depression amongst our HIV-infected patients is an estimated 50 to 60%, that's why, you know, today's talk will focus mostly on depression, because it is the most common psychiatric illness present in our patients. And within those patients who have a depressive diagnosis, the risk of suicide mortality is 3 to 5 times higher than the HIV uninfected counterpart. And this is research, you know, post card era. So these are patients who do have the opportunity of a prolonged life and an effective extended health care, but even with that availability, they do continue suffering from severe depression and are more likely than having a higher risk of suicide mortality than the uninfected counterpart. So some risk factors for depression amongst our HIV-infected population are the unemployed, the uneducated or low education, unmarried, having no or low income, so overall low SES, immigrants or having an indifferent or poor relationship with spouse, so spouse or family members. So with our patients, a lack of social support is a significant risk factor, and we'll talk a little bit more about this in a little bit. So these risk factors, what we have to be careful is that we don't want to stereotype in that if our patients do not fall within this list, then they probably are not depressed or vice versa. By no means. Everyone is could be at risk for mental illness or for depression, but it's important to be aware of what research has shown are, potential factors that place a person at a higher risk. So this diagram is more importantly to recognize. So if you read each item, you could see that many of these symptoms could mimic potential symptoms of HIV. So the importance here is to highlight that although many of the somatic symptoms of depression may be attributed to HIV or opportunistic or other infections or even side effects of medication, there are definitely symptoms that could be caused by depression. Now, obviously, the most common ones are bad mood, a chronic mood that's not just having, quote, a bad day, loss of interest or pleasure, what we call anhedonia, a sleep disturbance, a shift in their usual habits of sleeping, and it's not necessarily just lack of sleeping, an excessive need for sleep too could be a potential symptom. So appetite or weight changes, attention and concentration problems, changes in energy, psychomotor disturbance, so becoming a little more slow in their functioning, and feelings of guilt, and obviously, as I mentioned earlier, with more severe presentations of the suicidal thoughts. So as you may think as you read these, as I mentioned earlier, many of them can mimic common symptoms that a person with a medical illness, particularly HIV, may come, reporting to. So it's something to think about when you're ruling out potential factors that could be attributing to these symptoms. And just speaking briefly about the cognitive section here, as we know, as it's been established in research, that approximately 50% of our HIV-infected patients can present with HAND, or HIV-associated neurocognitive disorder. So these are patients that, with an HIV infection and a depressive disorder diagnosis, can have what we can call like a double impairment. So they would have even more difficulty with these cognitive issues that are present in about 50% of our HIV-infected patients. So that's something else to keep in mind, that depression would definitely exacerbate these symptoms. So many clinicians may be reluctant to ask direct questions about psychiatric symptoms, and understandably so. Many patients may be even reluctant to volunteer questions about psychiatric symptoms if not asked first. And actually, a 2010 study looking at attitudes towards depression in primary care found that about 43% of patients were hesitant to talk or to initiate the conversation about depressive symptoms with their PCP. And the most common reasons that they gave for not wanting to talk to their doctor included not wanting to be put on medication, or they didn't think talking about emotional issues were a part of their, quote, physician's job or something that should be included in their visit. They were concerned about privacy of their medical records, anxiety about who would have access to that information, particularly their employers. So, you know, the fear of being referred to a mental health professional and what does that, you know, mean for them, such as, you know, the concern of being branded as, quote, psychiatric patient with a mental disorder. So as you can gather, all of these concerns boils down to the issue of stigma. You know, that a lot of times for patients, one of the biggest barriers to volunteering information about any depressive issue or any psychiatric symptoms in general is this fear of being judged or being rejected or being misunderstood or being labeled. So these are very important factors to consider as you know, have a patient or you're treating a patient in front of you, and doesn't matter, you know, in what capacity. When you have a patient and you're providing, you know, health care, to be aware that they are most likely not going to volunteer this information, or even perhaps with just a general question or checklist, you know, skimming through a list, they are most likely going to not volunteer or deny the information or decline any psychiatric issue. So I think the way we ask the question and being aware that they are more likely to deny or not volunteer this information is helpful as we're providing care. And what's, I think, very important, too, is that patients with psychiatric symptoms, particularly depression, are often quite relieved that someone has asked about their suffering. So as I was mentioning earlier, to kind of break down the barrier of stigma, when a provider asks the question in a very, you know, non-judgmental, non-threatening, very normalized way, the patient feels that, you know, it's okay to answer, it's okay to open up, and it's okay to be honest. So it's very important to be aware of the way we're asking these questions. And so to introduce the subject, I think some general ways that a clinician might feel comfortable asking, and obviously you adjust the type of questioning to, you know, how it best fits your common practice, but here are some examples. I think that in order to best treat you, it's important to not only focus on your physical care, but your mental or emotional care as well. So I'd like to ask you a few questions. Another way of asking, a very similar way, may be, I'm concerned about your emotional well-being as well as your physical health, and I'd like to ask you a few questions. So like I mentioned, this is actually usually a sense of relief for the patient, and they're rarely offended by this line of questioning. You know, they could be at first, you know, offended if it's asked, you know, in a perhaps a way that they consider harsh or judgmental. So it's important to be aware of the manner in that it's being asked. And many of our patients, as I mentioned before, may not present to clinic reporting symptoms. It may be that they either do not recognize their symptoms as depression, or they are aware of their depressive or psychiatric symptoms, but again, due to stigma or any other barriers, they don't feel comfortable initiating the conversation. But in many occasions, especially with our HIV-infected patients, they may present mostly with behavioral changes that may indicate the presence of an underlying depression. So it's more likely that you're going to come across, or you could come across a patient that presents with behavioral changes than someone is being aware that their symptoms our depression and verbalizing it. So, potential behavioral changes that could be indications of an underlying depressive disorder could include a change in treatment adherence. So someone who's been, very responsible or dedicated to their care, have reached a non-detectable, viral load for a consistent amount of time, then you notice that they're missing visits or that there are changes in their labs and that there's just been an abrupt change that obviously cannot be explained by, any resistance or any medical reasons. It's something to consider as a symptom of depression. So an inability to make life choices, such as including those related to medical care or adjustment to HIV disease. So when they present to you in clinic with, preoccupation with a particular problem, usually one that presents as something minor. So when you see them just being extremely negative or that they can't, you're trying or you're presenting a hopeful outcome, whether it's, trying a new medication or if they have any other, symptom that came about and you're explaining to them that it's nothing serious, that it could be treated rapidly and effectively, but you see them just continuing to be overly preoccupied and negative about that situation, is something to consider. And also a change, obviously, in functioning. When you see them, in the past reporting an ability to be able to perform their daily activities well, and now they're having difficulties struggling with that. They present more disheveled than usual in clinic. You notice them, for example, they used to come with a partner or family member, and now they just say, I prefer to come alone. So being more isolated are potential signs as well. As I explained earlier, unexplained medical complaints that are not necessarily explained by their HIV or any other medical issue, like pain or fatigue, headaches, chest pains. These can all be signs of psychiatric issues. And also, I think in the last two bullets, interpersonal problems and presenting with difficulty behaviors in the medical setting could be important signs as well, whether it's a patient that you've known well in the past and you notice that these are not, their usual behaviors in clinic. They become very impatient, very irritable with, nurses or staff or even their providers. Or even if you don't know this patient as well, but you notice that they're becoming, that they've presented to clinic just overly upset, very irritable, and not being able to be perhaps calm down or relieved after the session. They continue to be upset, and you notice that behavior continues in your future sessions with them. Those could be also signs of a psychiatric presentation. So obviously, again, it's important not to generalize. Like I mentioned, a bad day is a bad day. Waiting for a certain amount of time in a medical visit could make anyone somewhat irritable or upset or frustrated. So we're talking here about obviously more extreme, more chronic situations, and not necessarily isolated factors. So when you start noticing that there are a few of these issues happening together and repeatedly, those are, signs to perhaps evaluate further or refer further for more comprehensive evaluation. And I think more importantly, something to notice, like I said, that these issues could happen to many patients as an, isolated event and not necessarily mean an underlying depression. But one thing to be aware of is that when I explained the factors of not being able to kind of see the positive or be preoccupied with a minor problem, in the presence of hopelessness, especially in our HIV-infected patients, could be a very serious sign. So in mental health, particularly in depression, the symptom of hopelessness is perhaps one of the most serious ones. And if you think about it, you know, what that means is that the person at the time is unable to see any positivity in the future, any hope, any, you know, and for a depressed mind, they translate that into, you know, there's no point in moving forward when there's nothing positive. Particularly with a chronic condition like HIV that's so stigmatized, they can see it as, you know, nobody's gonna want to be with me anymore, what's the point, or I have to take these medications for the rest of my life, you know, I can't do this. So when you see that sense of hopelessness, that's a serious sign to be aware of. And perhaps other less obvious connections between psychiatric illness or such as depression and HIV is that research has shown that there's a likely relationship between stress, depression, and immune response, such that HIV infection may progress much more rapidly in individuals with these depressive symptoms. So given the risk for worse HIV disease outcomes, you know, research and treatment advocates have used the presence of a coexisting psychiatric illness. And as I mentioned, depression is more likely going to be the psychiatric illness present. It's definitely a reason to suggest more aggressive and comprehensive clinical management of HIV. So many providers, once they identify or once the patient verbalizes, you know, either a history or presence of depression, or once the provider recognizes potential symptoms, you know, they already suggest for immediately a more aggressive and comprehensive clinical management, because the research has shown how this untreated mental illness leads to the non-adherence to medications, which, as we know, worsens the immune system and obviously ends up with the development of a drug-resistant, you know, viral mutations. And so it's very important to be aware that depression or psychiatric illness is not just a disease of the mind. So it has a very, very strong and direct link to physiological responses as well. So let's take a moment on this lovely Wednesday afternoon to test our knowledge thus far. And so what we've talked about up to now, what would you say, and this is obviously general research, statistics change consistently, but, you know, the bulk of research shows that depression is present in among what % of HIV-infected individuals. So as I was mentioning, the number itself is not as important. What we need to recognize, though, is how present or not it is amongst our patients. So we'll give a few seconds and we'll see the results shortly. And again, we're focusing on depression in this presentation, but towards the end, when we have more questions, then feel free to ask about any other psychiatric illness if you have any questions or anything more specific other than depression. So we see here, good. So the majority of us take the more than 50%, and like I mentioned, most research, obviously this varies, you know, between different SES and different demographic factors, race, etc., but the bulk of the research shows that it is about more than half of our patients. could be present or could be impacted by depression. So I think what's important to be aware of, as I was mentioning earlier, to be aware of the link or the relationship between mental illness or untreated mental illness and HIV care. And as you can see in the cycle, what we're talking about here and what to be very aware of is untreated mental illness. And what I mean by that is that just by having a psychiatric condition, it does not make you immediately more vulnerable to all the issues we've been talking about today. You can absolutely have a psychiatric illness that is well treated and under control and be able to have a very healthy, care, very healthy HIV presentation or any other medical condition that the person may have. You can have a very healthy and optimal overall quality of life. So it's the untreated mental illness that can bring about these issues. So research shows that untreated mental illness either can coexist with substance use or could lead to substance use. Many times an untreated mental illness, can become unbearable for patients. As many of our patients say, I can't deal with this sadness or these thoughts that I have about what happened to me in my life. It's just the pain is too much. So I use substance to, mask them, to make me not feel, this pain. So it's very, very common, even though this presentation will not necessarily focus on substance use, but it's a very common comorbid diagnosis with untreated mental illness. So we have to be aware that obviously this untreated mental illness coupled with substance use can lead to, very poor judgment, lack of inhibition, very high-risk behaviors such as, unprotected sex, which obviously can lead to either infecting others or reinfecting or acquiring opportunistic infections or any other infections, that are sexually transmitted. And thus, this in turn impacts, or brings about suboptimal health practices. So as you can see in the cycle, untreated mental illness that can lead to substance use, that will lead to just out of control, or high-risk behaviors, will make the person more sick and may lead them, with that state of mind, may lead them to be more non-adherent, to be missing their appointments or just fall out of care. And all of these factors can either cause or be caused by, severe stressors or genetics or the environment. So the reason why that's, bolded in red is that to be very aware of, it's hard to kind of be able to pinpoint what came first. Was it the substance use? Was it the untreated mental illness? Was it the HIV that brought about these symptoms? Or was it their high-risk behaviors, that brought about the HIV? As you can see here, that's this vicious cycle. But one thing that is very present amongst many of our patients, more likely the ones that are of a more low SES status, is the severe stressors and the environment and how that plays a role in their mental health and in their HIV care. So as many of you may know, HIV, is a very unique condition, and not only medically speaking, but because of the psychosocial factors that impact HIV and are impacted by HIV. And as you see here, so there is such a complex relationship between the mental illness, the substance use, so many other health problems a patient can have. Other factors, like that's why I mentioned earlier that particularly the low SES patients may have to factor in issues with homelessness and transportation, and having to deal with all of these issues when they're what we call their baseline. You know, their initial presentation was a very, very fragile one to begin with because of their long history of trauma or psychological trauma that they've had to, you know, endure in their life thus far. So many of our patients, you know, have an extremely chronic and challenging life with a lot of traumatic events, whether it's childhood, you know, or adult sexual abuse, domestic violence. Many of our patients could have acquired HIV due to rape or sexual assault. So they're presenting or coming in, or we're expecting them to maintain an optimal health and be adherent to medications and visits and all these complexities that are present in an HIV regimen. But we need to be aware of the history that they're bringing in and the presentation that, you know, they come to you, let's say, on day one. It's hard to be able to maintain such a complex regimen as it is an HIV care when they have all these issues to begin with. So it's very important to keep in mind, especially with patients that we're seeing are just having problems over and over again, whether it's not adherence or, you know, issues with attending visits, when those are red flags to perhaps intervene with additional help. And again, all of these factors could be contributing to that. So speaking of factors that could be contributing to, you know, the behavior or the presentation of our HIV-infected patients, it's important to recognize what research considers, you know, crisis points for our patients. So again, it's important to know that these issues could be considered red flags, but it's important not to exclude individuals that do not meet these factors, or just because a person does meet one of these or several of these, it doesn't necessarily mean that they have, you know, a psychiatric illness. So what's important, and the whole point of this information, is just to be aware or obtaining general information about what are considered crisis points or sensitive periods in our patients' lives that could be a good time to perhaps offer that additional intervention or screening or treatment referrals. So some crisis points are, you know, what could be seen as obvious learning of HIV positive status. So that is obviously a very critical time for someone, learning that they have a medical condition. Difficulty accessing healthcare services. So as I mentioned before, they have, especially at the beginning of their diagnosis, they may have multiple appointments to go to, whether it's, for example, something like SBAN or South Florida Network to get a case manager, then they have to go do labs, then they have to see their PCP and all these services, and you know, they have no means to get there. So these are just different issues to think about. Obviously, the introduction of medication, and that can mean something very different for everyone. So the introduction of medication could be that for them, the side effects is the most frustrating aspect. For other people, it could be, quote, being reminded that the pills remind them of the diagnosis, or being seen with a bottle in public. So the introduction of medication can be perceived by each patient very, very differently. And speaking of that, so the adherence to medications, kind of that commitment can be extremely overwhelming. You know, now I have to take this forever. You know, it's something that we hear that's very common at the initial stages of them being informed of the diagnosis, so that can be a very overwhelming piece that can be tied in with that hopelessness issue that I mentioned earlier. You know, instead of seeing it like sometimes I explain it as this is actually going to be that this pill is going to be, you know, the quote, super vitamin or super pill that's going to prevent you and from having to come here too often or having to have any or too many symptoms that will, quote, remind you of having the condition. So to kind of challenge them from seeing that pill of being that, you know, reminder or having to take this forever. So obviously the disclosure of HIV status can be an extremely overwhelming experience for a patient, and with that, obviously the rejection, whether it's a partner or family or friends or coworkers, you know, isolating themselves from the patient. And with that, as I mentioned earlier, the perceived stigma and discrimination is probably one of the most unique aspects of HIV in the sense of psychosocial factors or issues. You know, as many other patients may say, you know, if I had cancer, everybody would be like, oh, you know, poor you, you have cancer, I'm here to help. But when I say I have HIV, it's a completely different reaction, and you know, that stigma, that discrimination definitely isolates the patient, whether it's from actual care or from friends or family or from just general support that they need. So another crisis point could be a potential conflict, you know, how, like I mentioned, especially if they haven't reached optimal health or if it's the initial stages of HIV, they have, you know, the conflict between having to meet work or school needs and coming to multiple appointments. So the occurrence of any other physical illness or any other health changes due to HIV, like the neurocognitive deficits I mentioned earlier, loss of employment or worries about health limitations that could impact their functioning, recognizing new symptoms or the progression of the disease, which could lead to, obviously, hospitalization, which could be a very traumatic experience for them. You know, unfortunately, even post, you know, hard era, we still have many people, you know, dying from this and usually related to, you know, the non-adherence. So we still have many patients who have lost significant others, whether it was pre-heart or post-heart. That's obviously a very critical time. And by death of a significant other, meaning because of HIV or AIDS. So not necessarily, obviously a general death could be a very overwhelming experience for anyone, but when it's particularly related to AIDS, it's you know, considered a crisis point for the patient. So any major life changes, you know, childbirth, pregnancy, those are could be very stressful experiences for an HIV-infected woman because of, you know, fear of transmission, stigma, inability to breastfeed, all of these concerns that could be a major source of stress. And then, lastly, it's the necessity of making either end-of-life decisions or permanency planning decisions. Luckily, this perhaps is not as common as it was pre-heart, and our goal, you know, is obviously for prolonging life for, you know, the more we obviously can, but this is still obviously, and unfortunately, the case mostly for patients that are not adherent. So this is particularly salient for patients with, you know, an untreated or unmanaged psychiatric illness, because as we've been talking about up to this point, they are more likely to be non-adherent. They are more likely to have a more weakened immune system. So they would be the more likely patients to have a very either critically HIV or a more rapid progression or a more AIDS-defined presentation. So to kind of bring this into more like a translational presentation of how could this be presented in a clinic, this was a situation we had not too long ago in our primary care physician's office. So this was a 23-year-old African-American female who's not adherent to her medications, not adherent to her medical visits. As you can see, a very young patient, and presents to clinic more than anything because she's feeling very ill and presents with symptoms of pneumonia. So she reports to her primary care physician that she has just, quote, difficulty swallowing the pills. I just can't take my meds. You know, I hate those pills. They're very difficult to swallow. So psychology is called in for pill swallowing sessions, pill swallowing techniques. And, you know, after a few sessions with this patient, you know, with her initially stating, I just can't swallow them, you know, they're too big, I hate the sensation, nothing helps, not ice cream, not yogurt, not anything thick, this just doesn't help me. You know, after seeing that there are not necessarily any what we call physical barriers to literally taking the medication, we then kind of assess for more psychological barriers preventing the patient to take the medication. And so after a few sessions, she breaks down stating that, you know, everybody's quoting her, everybody thinks I'm stupid. Everybody can take a pill, put it in their mouth, and swallow it. I could obviously do that. That's not the reason why I don't take them. You know, I hate those pills because they remind me every day that I have this, that I'm living with this for the rest of my life. That's why I don't take them. As long as I don't see them, I'm able to take, you know, HIV out of my mind. So I bring this up as a case study because this could be a patient presenting to your clinic with a simple, I hate those pills, they're too big, I can't swallow them, they stay stuck, nothing works, and kind of giving these superficial reasons, which could potentially not necessarily be false. You know, I don't know of anyone who would enjoy taking, swallowing pills, but it's definitely not the main reason or the barrier for them to be non-adherent. So it's important that if you just see that this patient is presenting with these chronic issues and as many potential interventions you can give them, different ways of being able to swallow the pill, and they're saying, no, 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 I can't do it, and you're seeing in the labs that they're clearly not taking their medications, just keep in mind that that it's very commonly present, that these psychological barriers are one of the primary reasons that they are not adherent. So actually presenting a completely different presentation is another case study of a 30-year-old Hispanic male who's newly diagnosed and does have an extensive psychiatric or substance history and is also not adherent to treatment. So what's extremely different from case one is that his reasons to be not adherent have, quote, nothing to do with HIV. You know, HIV is the least of my worries. The barriers preventing this person from treatment is, you know, their extensive psychiatric history. So they're, you know, roaming the streets, trying to look for drugs, and getting the next fix, because without drugs, you know, this person is reminded daily of the extensive trauma he's been through in his life. And like I mentioned earlier, to cope with that pain, you know, he uses substance and he's using drugs, and there's so many issues going on at the time that kind of an HIV diagnosis is, quote unquote, on the bottom of his list. So it's important to, and the reason why, you know, I bring up these pretty different or extreme cases is that even though the presenting problem is the same, they're both not adherent to treatment. As you can see, there are pretty different reasons of why they're not being adherent. And from a mental health perspective, the treatments for both cases are extremely different as well. So for case number 1, you could, consider that HIV for the patient was a traumatic event and she's potentially having PTSD-like symptoms, and thus the HIV diagnosis and the processing of that diagnosis would be the major focus of treatment, rather than with this patient, you obviously want to try to get them as quickly as possible to be adherent to treatment, but there are so many other issues that need to be addressed first. That's something to be able to consider, in care. Okay, so second and last poll. This is a few slides back, but thinking about 3 factors that have a very intricate relationship and thus has an impact on HIV infection, that these 3 factors may progress or may make HIV infection progress more rapidly amongst our patients. So obviously, what we see in A, B, and C, all of them could play a role in exacerbating the progress of HIV, but there are 3 distinct factors that research has found have a direct relationship to the progress of HIV infection. So we'll give a few more seconds before we discuss the results. Okay, so let's see, and we have, yes, an overwhelming response for choice B. So as I mentioned, sleep, anxiety, cholesterol, neuropathy, obviously all of these issues or symptoms or presentations have an impact on HIV progression, but the direct, what research has found, the 3 factors that together show to have a direct impact is stress, depression, and the immune system. So now let's talk for a few more minutes about treatment. So as many of you may think as you're listening to the talk is, okay, so I'm treating the patient for many other reasons that are not HIV related, not mental health related. I'm not a mental health professional. My focus, is something different. We obviously have a distinct goal or focus when we see patients. So you may think, so what am I supposed to do if, I see these signs and symptoms? What should I do? So it's very important to be aware that it's not just recognizing that there's something wrong. There needs to be a further intervention to be able to know what's, causing the problem. So as I showed you in the 2 case studies, to know that there is that non-adherence is a presenting problem for those 2 cases is not enough. Why? Because the etiology or the causes for those 2 presentations of non-adherence are completely different. And by being completely different, the treatment approach should be completely different. So before we know what to do, we need to know what the problem is and its etiology. So as I mentioned before, each healthcare provider has a very specific, time-consuming task. So then whose responsibility is it to be able to assess and address these psychiatric issues? And what we need to be very aware of is that chances are that these patients are going to present these psychiatric issues to a non-mental health professional, so another healthcare professional, before they present it to a mental health professional. What do I mean by that? Chances are that they're going to either report or show these emotional, behavioral, or cognitive presentations to other healthcare providers because either they don't recognize these as being psychiatric issues, or again, because of stigma or some other barriers, they're not going to make it to a healthcare provider first. So it's everyone's responsibility to be able to intervene at some capacity. Obviously, the mental health professionals would then take over and offer the long-term care, but as a team, we need to work together because we as mental health professionals need that referral, need someone to be able to pick up those signs and symptoms so that patient can finally get to the, long-term mental health care. So as many of you may know, kind of the new or upcoming kind of approach, or not new or upcoming, but a very common one now is what we call the integrative care approach, this kind of one-stop shop model of integrated biopsychosocial approach to HIV care that incorporates the concurrent treatment of HIV infection and mental illness and possibly substance use. So it's this model that incorporates all treatment providers as a one-stop shop. And obviously, I think the reason why it's gained consistent and increasing recognition throughout perhaps the last decade or so is because it offers this patient-centered approach that's very effective, especially when you're addressing issues that are still very stigmatizing as mental illness. So I know it's definitely something that I've noticed here in our care, that we do offer this integrated care approach where we have psychologists and at times psychiatrists present at the medical clinics. If we just provide an appointment for them to come to us, it's not going, it's very likely not going to happen because of all the barriers I've been mentioning before. So by us coming to them, it definitely has been something very effective in our care. And obviously, this is not something that can happen. It's not feasible or available in every clinic. So there are other type of resources we can use. So they're very, very effective and free of cost self-reports that providers can use. These are just some samples that are available in websites like SAMHSA and different federal websites that offer these links to different type of self-report to provider assessments that can be used as a quick guide or screening for the patient. So as I was mentioning earlier, if some clinics may not have the availability, opportunity, or option of an integrative care approach, it's very important to become very familiar with your local resources, whether it's, having a formal agreement or an informal one with community clinics or your academic centers nearby, to be able to have that direct referral system to be able to offer to patients. And SAMHSA has a behavioral health treatment service locator that you can find on the references that if you're not familiar with what's in your area, it can try to narrow down options for you. And, the more standard treatment options are, obviously psychotherapy. And I think it's important to note that group psychotherapy has been proven very effective in our patients. Ironically, it's very difficult to get them in at first, again, because of the stigma, their fear of disclosing. But once they're in, it's for them an extremely effective social support. Like they often say, no one knows what I'm going through, unless you're living it too. So that type of peer support is extremely effective. And obviously, according to the severity of the patient's presentation, there's substance programs, psychiatric treatment, and again, just resources that it's important that you're informed of what's in your community. So I will pass on the baton to my colleague.
Thank you, Dr. Echenique. Franklin here, Miami. And how about let's open it up for some questions.
Right. It looks like most of the questions have been answered throughout the presentation, but one that came in, this is Clint, by the way, in Nashville, one that came in was kind of addressed towards the beginning, but we may want to get into a little bit further, which has to do with creating a space that's comfortable for people to feel safe to talk about their mental health. Would you have any advice on or any suggestions on how that type of environment could be created?
Sure, and that's absolutely key. And again, and when we were addressing the slide of how to ask the questions, you know, often the patient is more, you know, concerned about being judged and being, you know, stigmatized than the actual symptoms, you know, that they're experiencing. So to be able to present in a very, you know, genuine, empathic, non-judgmental way and just normalizing their experience, they will automatically feel much more comfortable in addressing these issues. So most patients, you know, I found the most defensive ones, the ones who, quote, say, I don't want to talk. Once you're able to offer them, you know, a very safe place where you can say, you know, I know this could be something very difficult, and I just want you to know that this is a place where you can talk about anything that you're going through and explain, you know, confidentiality and how this is information that, you know, is between, you know, you and the patient, and that, you know, that you're there, that the information is more than anything to be able to offer them the best services for them to feel better, that at the end of the day, we're here to help them feel better in any capacity and not just only physically. And that, you know, to normalize that it's very common for people to experience these issues. You know, like I often tell my patients, you know, when you're told that you have a medical condition, regardless of which one it is, you know, who's not going to feel sad, who's not going to be scared, particularly in HIV diagnosis, you add the component of, you know, anger, especially if it was a you know, sexually transmitted one. Who gave this to me? It was my partner who was cheating. Now I don't even know how I got this. You know, a lot of confusion. So to be able to address all of that and say, you know, hey, we're aware that this can happen. And I often tell my patients, too, that by no means am I trying to tell them how to feel, but I'm definitely, you know, here to provide them with support and with accurate information, because sometimes they can, you know, society is not as informed as it should be in 2016, and they may get incorrect information or very judgmental or stigmatizing, you know, comments out there, that this is kind of the safe place for them to be able to ask, to say anything that they want. So I think a lot of times by you just mentioning things like that, you're what we call normalizing the experience for them. You know, it's okay to feel like this. And it is an automatic sense of relief that it's just how the human, you know, how humans work and how a depressive mind can work. It just, they want to be able to share that, but it's, you know, so many factors holding that in that once you provide the safe zone, it's just, they automatically want to feel open and ready to talk.
That's great. Thank you so much for speaking to that further. Franklin, do you want to go ahead and wrap up, and then we will give some people some final information?
I just want to thank everyone for attending today's webinar. Thank you, Dr. Echenique. And we encourage you to go ahead and perform the post-evaluation. It is very important for funding requirements. And good news, everyone, the PDF slides will be available after this presentation, this webinar is done.
Yeah, great. Thank you so much. We will be sending out a follow-up email that will contain a link to the slides of the PDF along with any additional updates and a recording that will be posted later this week. We want to thank you all so much. Thank you for attending and joining us, and we will see you all next week for our next webcast Wednesday on telemedicine. Thanks again.
Thank you.